Alright, welcome to Step 2 USMLE Crash Course. This is the podcast specifically designed to discuss some of the very high-yield stuff, some of the questions you will be seeing in the U-word, you will be seeing in the NBME, and hopefully you will be seeing those concepts in the exact exam, Step 2 CK, mostly. But I will be emphasizing most of the time on the Step 2 CK here. Okay, alright. So this is specifically for esophageal, high-yield esophageal conditions that you should know for your step exams, right? So first of all, when we talk about hiatal hernia, when we say hiatal hernia, what does it mean? Hiatal hernia means that your stomach is herniated upward through the diaphragm. And there are two types, sliding hiatus hernia and the paraesophageal hiatus hernia. 95% of the time, hiatal hernia is always sliding. What is sliding now? That your cardia of the stomach rises upward through the esophagus, esophageal hiatus. So stomach rises upward through the esophageal hiatus, which is opening in the diaphragm where esophagus passes, right? So there's an abnormal relation of cardia to the lower end of the diaphragm. Very important. Abnormal. If they want to ask a question on hiatal hernia, they can ask you about this thing. And they want the mechanism. Mechanism is abnormal relation of cardia to the lower end of the diaphragm. 5% of the time it's paraesophageal, where your fundus of the stomach herniates upward through a hole of the diaphragm adjacent the esophagus. Right? Protrusion of the fundus into the chest. Protrusion of the fundus into the chest above the level of T10. This is the answer for paraesophageal hernia. Protrusion of the fundus into the chest above the level of T10. Right? So it is associated, most of the time it is associated with GERD. And we usually don't do surgeries. Surgery is usually not indicated in this thing. And endoscopy. This is specifically for the Step 2 CK. Upper endoscopy is diagnostic for hiatal hernia. Right? So GERD symptoms with upper endoscopy showing sliding or paraesophageal hiatus hernia, they can ask you about any of these things. What about GERD now? GERD is when there is a irritation of esophageal mucosa by gastric acid. Now why? Because of your esophageal sphincter tone is. Let's talk about GERD now. What happened in GERD? There is irritation of whole esophageal mucosa by your gastric acid. Why? Because the tone of your esophageal sphincter, lower esophageal sphincter is decreased. And you know what? USMLE actually cares about the cause, the obesity as a risk factor for your GERD. Why obesity now? Obesity, can increase the stretching and pressure applied to your lower esophageal sphincter, right? So it leads to GERD. Hiatal hernia is also a risk factor. And what they want you to know, the classic presentation for GERD is there will be burning in the throat, burning in the chest after eating a meal. And it can present with nocturnal cough or recurrent pneumonitis as well, because these are very high yield findings in these patients who don't have classic esophageal irritation symptoms. But more, in GERD, there is one very important complication. It can lead to Barrett's esophagus, which ultimately leads to esophageal adenocarcinoma. So what's the first step in diagnosis? Remember this, first step in diagnosis is 2-week trial of proton pump inhibitor. 2-week trial of proton pump inhibitors such as omeprazole. It will decrease symptoms. PPIs, they're more efficacious than your H2 blockers. And if you see both in the question, PPI and the H2 blocker, then you should answer PPI. Right? So in some questions, they can give you a 2-week trial of H2 blocker, but PPI shouldn't be listed. If PPI is listed, then you should be answering 2-week trial of H2 blocker, right? If a trial of PPI doesn't work, then go do 24-hour esophageal pH monitoring. The last resort for GERD is nasal fundoplication. This can be asked as well, right? So answer can be written as fundoplication alone in patient with severe GERD, like this also like shows up on pediatrics as well, where they say infant with severe GERD and fundoplication can be the answer here, right? Pediatric GERD is what? It present with coughing up milk 2 to 3 times daily. Will not be described as high energy or forceful, because if they are high energy or forceful, that will be pyloric stenosis. It will not be bullous as well. If it's bullous, then it's duodenal atresia or annular pancreas. It will not occur as a choking or spitting up during the first feed. If it's that, then it's tracheoesophageal fistula. Right? So pediatric GERD is again the coughing up milk 2 to 3 times daily, but again, you should know the differential diagnosis for GERD in pediatrics. So immature lower esophageal sphincter will be present as an answer for your pediatric GERD here. It's not complicated, but some says, can you get GERD in kids? Can GERD happens in kids? But yes, it can. Treatment is what? How do you treat pediatric GERD? You will be giving thickened feeds, like you will be adding dry rice to the formula milk. And yes, very important to know, prior to any use of the PPIs, you should do a positional change as well. Positional change and thickened feeding. This is the number one for pediatric GERD. Then you go with the PPIs if you really need to. Right? Let's talk about Barrett's esophagus. Barrett's was what? Metaplasia happened of your distal esophagus, right? There will be conversion of non-keratinized stratified squamous epithelium into columnar epithelium with goblet cells. Now these secrete columnar epithelium with goblet cells, they secrete mucus actually, right? They can also give you sometime a question as a intestinal columnar epithelium too, right? Stomach does not have goblet cells. It has neck cells, mucous neck cells. These are called foveolar cells. So intestinal columnar epithelium is present in your stomach as a Barrett's, in your esophagus as a Barrett's esophagus. What is the major risk factor when you're talking about Barrett's? It leads to esophageal adenocarcinoma. Very important. And it can appear grossly red on upper endoscopy. When when they give you endoscopy in the question, they want you to identify this. The next best step is do the biopsy, confirm the presence of Barrett's metaplasia. Right? Alright. What about adenocarcinoma? Because it affects your lower 1/3 of esophagus. So GERD happened, GERD leads to Barrett's esophagus, and Barrett's ultimately leads to adenocarcinoma. Right? So it presents in patient over 50 mostly, who has history of GERD with either a new onset dysphagia to solids or dysphagia to solids that progresses to liquids as well now. Right? So this is very important. The new onset dysphagia, it's referred as like 3 to 6 months and history in the patient with, right? Like the patient can give you a history of 10 to 20 years of history of GERD, and now coming to you after 3 to 6 months having a problem with new onset dysphagia. What are you gonna do specifically in the adenocarcinoma cases? They want you to go with immediate endoscopy. Don't choose barium and with this anything first. Do endoscopy for adeno if you identifying the cancer, right? So sometimes they can make you choose endoscopy straight up, but they will tell you the last line is endoscopy was performed and now it is showing the structure. Then what's the best step? You should biopsy that structure, right? So confirm the adenocarcinoma first. Right? What about squamous cell carcinoma? Squamous cell carcinoma usually affects your upper two-third of the esophagus. And one of the very biggest risk factors in squamous cell carcinoma, and USMLE wants you to know, is heavy smoking. Smoking, alcohol use, yes. Burns, chemicals, eclasia, they are the risk factors, but they don't ask that much. Heavy smoking and alcohol use. And how these patients present: over 50, who is heavy smoker, plus new onset to dysphagia to solids or dysphagia to solids that progress to liquids. Again, same thing. USMLE wants you to know that immediate endoscopy is the answer if that structure or lesion is present, and do the biopsy of that lesion. right? Okay, I'm going to talk about Zenker's diverticulum now. Zenker's diverticulum is what? This is an outpouching of the esophagus. Outpouching of the esophagus above the cricopharyngeus muscle. Like just above the, upper esophageal sphincter, we have this muscle, cricopharyngeus muscle, and that above we will get this outpouching, right? So, cricopharyngeal muscle spasm can happen, uncoordinated swallowing can happen, dysphagia can happen, and increased oropharyngeal pressure can happen. So these are all the mechanisms that can lead to formation of the Zenker diverticulum. So spasm, uncoordinated swallowing, dysphagia, or increased oropharyngeal pressure, right? This is actually a false diverticulum. You should know that. It usually contains mucosa and submucosa, right? Overweight male comes to you with over like 40 to 50 years old with gurgling sounds when the patient swallow, or there is regurgitation of the undigested food. That is the answer. Halitosis, right? Sometimes they give you halitosis, but most of the time they don't. And what they want you to know is you will be going with the diagnosis with the barium swallow here. You do the diagnosis with barium swallow, and the treatment should be diverticulectomy, right? Remove it. Okay. What about ecclesia cardia? So now the tone of here in ecclesia cardia, the LES tone, lower esophageal sphincter tone, is tightened, increased, right? Because of some neurons in the orbic plexus, they lost, and it leads to increasing the tone of the lower esophageal sphincter, right? So they can give you the question here with enteric ganglia. Enteric ganglion is the problem for the ecclesia. So enteric ganglion is the answer because orbic plexus is again in the enteric system. So enteric ganglia can be the answer too, right? So what else they can ask you? So in question they can present to you that this ecclesia as a dilated esophagus with the construction of the gastroesophageal junction. So dilated esophagus with construction of gastroesophageal junction, right? So what will happen? Patient will be presenting to you with solids and liquids, both dysphagic from the start. This is in contrast to cancer, which will be new onset dysphagia to just solids, or progression from solids only to liquids, right? So high yield point here is that neurogenic causes of dysphagia like ecclesia cardia can cause both solids and liquids dysphagia at the same time. So most of the time it's idiopathic. Viral can follow as well. Rarely it is caused by Chagas disease, right? So, in questions, and then they want you to know that South American trypanosomiasis, this is also called Chagas disease, can be the cause for ecclesia. What are you going to do? So first step here is do barium swallow. We'll be giving you bird's beak appearance. And after the barium is performed, go with the esophageal manometry to confirm this thing. Esophageal manometry is diagnostic. This is a pressure study. How do you treat? Treat with pneumatic dilatation, pneumatic balloon dilatation, followed by cutting of it. Myotomy, Heller myotomy can be done as well, right? So pneumatic dilatation can be used, calcium channel blockers can be used, botulinum toxin can, but they don't really ask about these things. But pneumatic dilation is one of the treatment they want you to know that, right? Okay, what else can affect your esophagus? Systemic sclerosis. So this is a very important idiopathic autoimmune condition in which you have there will be fibrosis of multiple organ systems, and there will be hardening of the tissues as well. Now in esophagus, it can cause GERD. Again, they want you to know that here in systemic sclerosis, there will be decrease in the lower esophageal sphincter tone and decrease in the esophageal peristalsis, right? So there will be dysmotility component in here too. In crust syndrome, like in crust, what happened? Crust is what? Calcinosis, Raynaud's, esophageal dysmotility, sclerodactyly, and telangiectasia. In same way, it presents like this, right? Esophageal perforation can happen. Now, because it can be iatrogenic from your endoscopy, when you do endoscopy, it can perforate your esophagus. It can occur after Bohr-Haave syndrome from increased pressure due to retching, vomiting, or straining. Bohr-Haave can happen. So what we want you to know in esophageal perforation is you have to choose water-soluble contrast swallow. It shows accumulation in your mediastinum, right? So if they don't mention this, they will give either recent endoscopy or straining, plus the patient might be having acute low blood pressure with high heart rate, then you have to eliminate the other ancestor. Water-soluble contrast I mentioned. This is called gastrographin. It's usually used in suspected perforation because the contrast will leak into the mediastinum and barium can cause mediastinitis. We don't use barium in these cases. Right? In contrast, if patient has aspiration risk, we use barium and not gastrographin because gastrographin can cause pneumonitis in aspiration risk cases. So what's the treatment? Esophageal repair should be done in these cases. Mallory Weiss tear classically present with retching, vomiting in an alcoholic case. So that causes your stretching and the tearing of the gastroesophageal junction. Small amounts of blood will be leaking in the vomitus, right? Can also present in the patients with the eating disorders as well, like in hyperemesis gravidarum too, right? So highest yield point in Mallory Weiss tear is it does not cause high volume hematemesis. If the question asks you that the patient has high volume blood, that's not this thing. That is something else. Like it can be ruptured varices, right? Esophageal varices can do this. Let's talk about esophageal varices first. But these are the, there will be, when we talk about esophageal varices, we obviously know cirrhosis is one of the very important cause. So what happens is there is superficial esophageal veins, they get enlarged and tortuous. Why? Due to portal hypertension, where the cirrhosis cases or splenic vein thrombosis can cause it. The mechanism, in the setting of cirrhosis is simple. Your left gastric vein connects the esophageal vein to your portal vein, right? So in the setting of increase in the portal pressure, this pressure backs up to the left gastric vein, which backs up to your esophageal vein, and yes. So many questions. They want you to know that left gastric vein is the answer for the vessel responsible for the varices, not the esophageal. Remember this. So left gastric vein is the answer. What about in splenic vein thrombosis? In splenic vein thrombosis, what happened? Your splenic venous pressure increased leads to formation of the collaterals to circumvent these thrombosis. So there will be nearby veins formation with small tributaries from the splenic vein, and the left gastric vein is one of them, causing increase in your gastric pressure, increase your esophageal venous pressure. Like most of the questions, they will give a patient with high volume hematemesis. Mallory Weiss is just a little blood, but it's high volume. Ruptured varices, most 50% of the time they are lethal. Because so much blood. Some of the question, like not much of them, but some of them cause just a little blood. If like varices is like a friable but not ruptured, it can cause little blood, right? But the question will be obvious of cirrhosis, and they might want you to know that the left gastric vein should be the answer, right? So what are you going to do? Propranolol is for your prophylaxis, not for your acute treatment. Don't go with that. So prophylaxis with propranolol. Treatment is only endoscopy plus bending. Octreotide can also be used for, acute bleeding, but endoscopy plus bending is the best answer in the USMLE. Right? So there's one question there that the patient has a very, very low BP due to ruptured varices, and the answer is actually IV fluids, where endoscopy is the wrong answer for. Right? So, but you can say that you said that endoscopy and bending is what we do first, but no. But you always have to address ABCs first on step 2 CK. They could by all means, patient has O2 sats of 50%, and the answer is give oxygen before fluids and then go with endoscopy. So remember in step 2 CK, first see the ABCs all cover it, and then go with these things, endoscopy and bending and stuff. Right? I have 3 more conditions to talk on esophagus here. there's a very important condition called diffuse esophageal spasm. What happened in this is an idiopathic spasm of your esophagus. All you need to know in question that this esophagus, this diffuse esophageal spasm, that can cause pain that can mimic angina pectoris. And the patient will be negative for cardiac findings. Like 35-year-old comes with these things and negative for cardiac findings, but it can mimic angina pectoris. When you do the barium swallow in these cases, we will be seeing corkscrew appearance. Nutcracker esophagus is one of important similar condition that is due to idiopathic hyperperistalsis. The pain is actually very similar to diffuse esophageal spasm. Eosinophilic esophagitis. So, they can give you a condition. This is because this is a idiopathic allergic condition of your esophagus with difficulty swallowing. And in the epithelium, they will be giving you eosinophils. It's like no shot. Endoscopy will show what? Endoscopy will show trachealization of the esophagus with concentric rings. Very important to know. If they want you to give you the findings of endoscopy in eosinophilic esophagitis, is trachealization. Like it will like trachea if the esophagus with concentric rings. And patient always have a history of asthma or atopy in eosinophilic cases. Right? What about Schatzky ring? It doesn't exist in the USMLE mostly, but it can present sometimes, right? So a narrowing of distal esophagus that could be considered as differential diagnosis of your eclasia. Now, we don't see this kind of diagnosis in these questions. So very important diagnosis of there is a ring, like a ring, and it leads to narrowing of the distal esophagus, and yes, it can be a differential in the cases of eclasia. So that's it for these the esophageal high yield conditions. They ask the questions on them from them. I hope you like the podcast. We'll meet again. Have a very good day. Thank you.